Good morning, dear friends. Happy Sundays to all of you. I'm so sorry not to be with you there. Turkish Airlines has updated my departure flights, and when you are listening this lecture from video, I will be flying back to Istanbul. But please be free, feel free, and let me to know in case of any question about this presentation. Happy to help you to give some answers. So today I will update you about the HPV DNA screening, what's going on. You know, this topic is really very important. Cervical cancer is a cancer that can be prevented, even can be eliminated with the WHO program. And we have to update our information annually because the scientific literature is really growing very fast. My dear friends, for the last 3 years, ESGO finally has a prevention committee, and as you can see, we are collecting almost all famous epidemiologists and experts in HPV in Europe. The idea is just to find the best answers, evidence-based answers for your questions about the cancer prevention, and of course, especially for HPV and cervical cancer elimination program. And we are doing really good job with very, very important publications. Remember, WHO already announced the cervical cancer elimination program with vaccination, screening, and adequate treatment. About the screening, the target is to screen 70% of the ladies at least 2 times in their life. One is when she is 35 and one is 45 years old. So of course you can do in a more frequent way, but this is the minimum for the low middle income countries. The target is to screen 2 times when you are 35 and when you are 45. And of course, WHO also points that the pap smear will not be used anymore after 2030. Instead, we will move forward with HPV testing. HPV DNA or mRNA test can be used with or without triage. If the country is financially cannot afford, then you can go with an HPV standalone test. But if it is better, if you can make some sorts of triage, like genotyping, like VIA, depending on the infrastructure of the country. But it's 100%. We are sure that we have to use a high performance test, and for this, it's not cytology, it is not a visual inspection with acetic acid, but it is HPV test with or without additional triage tests. And what WHO asks, I told you, minimal 2 times when you are 35 and 45. But of course, it's better to make it in a more frequent way, depending on the infrastructure of the country. But the interval of 5 to 10 years is sufficient, really, for elimination of the cervical cancer. And this is what's going on with after this announcement in Europe. As you can see, day by day, many more countries is switching from pap smear to HPV DNA screening. And I believe until 2030, almost all Europe will finish this switch in the cancer screening program. ESGO Prevention Committee, including, of course, as the PI Mark Arbin, has did a very important survey. In addition to Europe, we search what is going on in the world, and as you can see, many countries, even in Africa, is now again switching to HPV screening, and it is really now off for the pap smear. The countries is converting to HPV DNA. Why WHO pushed all countries? Because why? What was the problem with cytology? Well, actually, first of all, it has some scientific problems. We are using pap smear more than 50 years, but in many countries, it's really cannot be implemented successfully. First of all, it has some scientific problems. For example, sensitivity is around 50 to 60%. What it means that you go to a village and you can only detect 50 to 60 of 100 cancer cases. There's high false negatives. The pap smear result can, change from one laboratory to another. It also depends on quality assurance and your experience. So the reproducibility is very, very low. And more than the scientific problems, it also has some very important organizational problems. You really need a lot of thousands of manpower, cytopathologists to evaluate all these pap smears in a really well-regulated quality assurance program in a well-defined time interval. But this even could not be implemented in many developed countries. The successful, for example, pap smear program could be implemented in around 12 countries in Europe. So many countries had difficulties in this respect for the organizational issues. And when you switch to HPV from pap smear, first of all, you should know that this is not something new. There is 20 years of research behind. There are more than 200,000 females that's followed more than 8 years. So 2 rounds of screening, and it's in different countries, UK, Italy, Finland. We have lots of data. And after all these 20 years research, what we have found that HPV screening is really an objective test. It can be really, it does not change from one laboratory to another. It can be automated and centralized. You don't need so much manpower. It's a machine that gives the results in a given time interval. The negative predictability is so high. The screening intervals is really can be extended to 8 to 10 years. It can be done even in self-tests like urine or self-vaginal swabs. And what we can say is that, as you can see, even these tests can be used in self-tests. Mark has did several meta-analyses showing that if you use a validated PCR test, the results are the same compared to the physician-taken samples. This is really another advantage, especially in low middle income countries, in conservative populations, in ladies who are not attending persistently to cancer screening, but they work in self-tests. After all these 20 years research, almost all guidelines, including United States and Europe, has been updated. Wherever you go, you will see that HPV DNA is standalone sufficient for HPV DNA screening. Now, if we look to the latest efficacy data, which is very, very important, I want to update you. First of all, if you see, this is the recent meta-analysis last year published, including Australian and Canadian data, showing that if you look for sensitivity, HPV DNA is 44% or 47% is higher compared to pap smear. So when you go to a village and make a screening with pap smear, which is the sensitivity is around 60%, but with HPV DNA, it is 94 to 97%. So it's very nice. Another issue is the negative predictivity or prevention at the second round. As you can see, when you are HPV negative, 8 years later, the risk of CIN3 or the risk of cancer is 80% less compared to pap smear. So this is much more important so that you have really higher protection with a negative result, and you can reassure your patients that you can come 5 to 8 or 10 years later. So the second question, which HPV tests? We have thousands and thousands, even believe me, around I think 400 HPV DNA kits that's produced in the market. But you cannot use all these tests in cancer screening. You have to reassure the ladies for the validation and the long-term data on cancer screening of these new HPV DNA kits. This is an ESGO prevention paper just recently published, and you can see that these kits, that's around 13 or 14, can be used safely, and you can reassure all patients that please, you have to check which HPV tests you are going. You have to ask to your countries which HPV test you are using for cancer screening, and these are the internationally validated, and you assure that this is really high quality HPV DNA kit and can be used in your country, in your patients, or in your friends. The third question, the recent data on the self-tests. Well, vaginal swabs, this is a very recent data, unpublished yet, but you can see that if you are using, among these validated kits, if you are using a hybrid capture or cervix, these are signal amplification tests, it does not work. So, so a hybrid capture or cervix, you cannot reassure a lady that they work in a self-test. But for the others, for all other validated tests that are using a PCR technology, as you can see, clinical sensitivity is the same when a doctor, when you compare a doctor taken, physician taken versus a patient taken sample. Another coming up self-test is the urine test. We have many publications comparing different kits in the urine, and Mark has updated all these data that will be published very soon. And what we can see is that if you use a simple urine container, it does not work. Sensitivity decreases to 87%, but some spatial urine storage media like poly-P, and you can see the relative sensitivity and specificity is the same. So in some ladies, we can use urine tests, but for these urine tests, you have to need spatial urine containers. Another topic is that's going very fastly in the recent years is mRNA test. You know, HPV DNA is successful, but the recent technological advances bring us also mRNA test. What it means, you know, HPV enters, then integrates the DNA. That's what we are looking, HPV DNA. And after integration, it produces mRNA to produce oncogenic proteins. So what it means, mRNA tests can show more persistent, more long-term HPV infections compared to HPV DNA tests. When you detect the DNA, it can be transit, but the RNA test can be more, can show more long-term HPV infections. And then we do have several products, but among these 4 to 5 mRNA kits, the most validated, the mostly highly studied kit is the Aptima that looks for HPV E6, E7 mRNA from 14 high-risk HPVs. If you look, if you compare this mRNA test with the DNA test, what we have in our hand as the data, well, for CIN2 and for CIN3, we have very similar sensitivity. So mRNA and DNA tests are almost the same. As you can see, the relative sensitivity is same here. mRNA tests can be a little bit higher specificity, of course, because these are not transient HPV. But for me, is what I can say. It does not produce so much significant difference. So for your countries, for your screening, you should have either a validated DNA or a validated RNA test. The cost should be much more important for the countries. For these new coming mRNA tests, especially for Aptima, I have to underline two realities: that the long-term data for Aptima, we have to wait a little bit more until now, the data is very reassuring for a screening interval of 5 years, but for a screening interval of 10 years, there is only one data recently published coming from Canada, that is a focal decade trial showing a very similar safety of these tests compared to the DNA tests. But for the 4 to 5 years, it's really nice and comparable to already validated DNA tests. A second message about the mRNA test is the self versions. As remember, in the DNA test, in the PCR methodologic test, it was very nice, but the data on mRNA test is really not sufficient. So similar to hybrid capture or Cervista, mRNA test cannot be used yet for self-tests. We have to work more on that. Dear friends, there is also a feature that is what's going on in cervical cancer screening. This is the first American guidelines updated 2 years ago. What they do suggest that based on your age, vaccination story, previous screening story, you have a risk of CIN3. And based on this risk, individually, you can be referred to colposcopy, or you can be observed, or you can be just go to the routine screening program. These American guidelines suggest a 5% risks to go to a colposcopy immediately. In the Europe, we usually prefer 10 to 20% CIN3 risk. First, Norway has implemented this personalized risk, and now ENAGAGE together with these famous HPV experts in Europe. As you remember, we are doing a risk project in 7 packages, and all these will define a risk-based new cancer screening program for Europe for 2025. And our aim is again the same. You will have a personal risk. Some people will go to annual screening. Some people will go to screening every 10 years. This type of risk-based screening in the future will really avoid unnecessary screening, unnecessary anxieties in the low-risk women, and it will really produce an important cost reduction in the countries for screening programs. So our risk ambassadors will work for the better screening of European ladies in the future, and we will come together in this meeting with them. Dear friends, don't forget, HPV is a virus that we can all beat, either lower, higher middle income countries. We can come together and we can fight, prevent, and even eliminate a cancer. But I know that this cannot happen without voluntarism, without a heart that really believes and trusts on science. So we need you, my dear friends. Without the voice of the patients, we cannot be successful in all these advances. Thank you very much, and waiting for your questions on my email. See you, dears.